Hello, I am Eddie Guerin, and I'm happy to be able to present to you today on basics of immunotherapy in non-small cell lung cancer. I think it's really very interesting to note that although today we certainly consider non-small cell lung cancer to be among the immunoresponsive tumors, it really wasn't very long ago that that was considered to be very much untrue, that lung cancer was not a tumor that people were enthusiastic about using immunotherapies. And from our institution, it's always been exciting. There's been a long tradition of enthusiasm about the role of inflammation and adaptive immunity in non-small cell lung cancer. But really, early efforts were not particularly successful in that area. One area that was of particular interest that we frequently looked at in my fellowship training was intravenous interleukin-2. And this was a commonly used therapy for what were at the time considered immunoresponsive tumors, and those were melanoma and renal cell carcinoma. And there were studies that looked at the role of interleukin-2 in non-small cell lung cancer. And as was the case in melanoma and renal cell carcinoma, where these agents did develop a foothold, in non-small cell lung cancer, the toxicity remained as would be anticipated, but really the efficacy was not there, and that was largely abandoned as an approach. One approach that did generate a great deal of enthusiasm in non-small cell lung cancer was the idea of vaccines. And you can see here, this is from a review that was sort of done prior to the really rapid expansion, or at least the most rapid expansion portion of immunotherapy in non-small cell lung cancer. And you can see a listing of many different approaches, including vaccines, cellular therapies, none of which have really joined our armamentarium of treatments to date. And I can't highlight all of these, but I will give a few that I think are somewhat instructive. So one that I will show is this study of LBLP25 versus placebo. So this was for patients who had stage 3 non-small cell lung cancer. It was a large trial, a double-blind phase 3 study, and patients were randomized to this vaccine approach versus a placebo. And what you can see here was that there was at least a suggestion of a benefit in terms of time to symptomatic or radiographic worsening. But what you see here is that when you look at the overall survival, there was really no benefit, and this did not become part of our treatment armamentarium. And one thing that I will note that is of some interest, particularly in light of data that you may be hearing about later today from the Pacific study, of the role of immunotherapy after chemoradiotherapy. And the overall survival among patients who received concurrent chemoradiotherapy did look impressive. But nonetheless, this was a post hoc analysis, and this did not become a standard approach. One study that I was involved with looked at this agent, which was a vaccine derived from several killed tumor cell lines. Again, there are multiple different analyses showing groupings for overall survival here, but as you can see, none of them show a clear benefit of the agent. This again is from a large study from an agent that has not become part of clinical practice. In many respects, what is probably the biggest approach in any lung cancer trial that I'm aware of, at least in terms of a therapeutic trial, was for a vaccine directed against MAGE-A3. And this was an interesting study, and I think does illustrate some of what will be the challenges as we attempt to have more refined immunotherapies. This was a MAGE-3 directed therapy, and it was restricted to patients who had a specific HLA type. This was the HLA-A2. And although it is a fairly common HLA type, still, this study started, as you can see, with well over 10,000 patients screened to randomize a little over 2,000. This, again, was, as I say, a major effort in the field. And I would say in the end, somewhat did dampen enthusiasm for immunotherapies in general. As you can see, there is no difference in terms of disease-free survival, no difference in overall survival, and not even clear differences in sort of subset analyses. I think one of the even more complicating features involved with this is that one of the questions is, were you not able to generate an immune response? And the answer really is no. There is evidence here that an immune response was being generated. And you can see here, if you look at the antibody concentration against MAGE-A3, which was the target here, you can see that the antibody concentration was clearly there, but nonetheless, it did not confer a therapeutic advantage. And this was, again, a very large effort and a disappointment. But as you now are aware, of course, the field did not give up on non-small cell lung cancer as a potentially immunoresponsive tumor. And in fact, right now, the great majority of patients do receive immunotherapy as part of their initial therapy for non-small cell lung cancer. The promise of immunotherapy, and the reason that at our institution, Steve Dubonnet has had a long interest, and at other institutions, obviously, a whole host of people, has been this potential for durable response. And of course, this has been shown now in patients who received ipilimumab for melanoma. Melanoma, obviously, a different disease, but I choose this slide because I want to show what has been a source of enthusiasm for people. And that has been that although not everyone responds, what you can see is that among those patients who do respond, as would be anticipated with an immunotherapy, these responses tend to be of tremendous duration. And this is something that has been shown with really 10-year follow-up in melanoma, although I've not shown slides now from the experience with both nivolumab and pembrolizumab. It has been shown that of the people who took part in the original studies, over 15% of them remained alive 5 years afterwards if they received a PD-1 inhibitor for non-small cell lung cancer. So I take this slide from a New England Journal of Medicine article from my colleague, Tony Ribas, and this shows some of the biology, of course, in that is seen in the immune checkpoint inhibitors. Here you see in the priming phase, he shows an antigen-presenting cell interacting with a T cell and shows these different interactions. Of course, in both the priming phase CTLA-4 schema that you see on the left and the effector phase, the PD-1 schema that you see on the right, you have an antigen on the MHC molecule that interacts with the T cell receptor. In terms of the CTLA-4, you have a co-stimulatory molecule, B7, which binds to CD28, but it can bind CTLA-4, which prevents that stimulatory activation. And there, of course, ipilimumab, which I already showed, is an antibody against CTLA-4 that leads to increased activation there. In the effector phase, where PD-1 and PD-L1 is shown in this schema, you generally will have this interaction, including this interaction at the level of a cancer cell, and that antibodies against either of these, either a PD-1 antibody or a PD-L1 directed antibody, is able to inhibit this inhibitory stimulus to the T cells, and therefore also can be immunostimulatory. So this went from really a theoretical issue to a really practical issue very quickly. So you can see this article from June of 2012 from Suzanne Topolian looking at patients with Nivolumab. And in this, there were several different histologies that were looked at. It was updated by Julie Bramer at ASCO in 2013, showing that nearly 20% of patients in previously treated non-small cell lung cancer had a response to Nivolumab, a PD-1 inhibitor. And nearly a quarter of the patients at what became at least the initial approved dose of 3 milligrams per kilogram experienced a clinical response when they received Nivolumab for previously treated non-small cell lung cancer. There are, I think, important components to focus on that people have continued to look at that I think underpin the biology and will help explain some of the other studies that you're going to hear about today. And I've sort of broken these into sort of three groupings based on Tony Rivas's review article that I showed. One is this, looking at the mutant peptides. Of course, that is what the immune system should be able to recognize as foreign, should be able to recognize should not be there, and should ideally lead to the ability for T cells to eliminate the cancer cells. The second point is antigen presentation and T cell receptor recognition. I think that there's probably more data available today on the prior rather than the latter, but we'll discuss that a little bit. And then what I think has some greater familiarity and will be discussed probably in much greater detail is overcoming the immune checkpoints as a potential way of preventing PD-1 or PD-L1 inhibitors from being effective approaches. So again, we will start with mutant peptides. And there has been this idea for quite a while that that the more mutations that one would have would be associated with greater efficacy of the immune checkpoint inhibitors. Again, these mutant peptides is really what the immune system should be able to recognize as being foreign. And the sort of empiric data, this is TCGA data looking at mutational burden. And what you can see is that if you start with melanoma on the right of this figure and start going left, it almost looks like you're marching through the approvals of PD-1 or PD-L1 inhibitors. And this led to the idea that having more mutations would be associated with a better degree of efficacy. There was some somewhat simplistic view that also sort of furthered this, and that is the relationship of efficacy with smoking. And what you can see here is that in non-small cell lung cancer, in this data set, that smoking was associated with at least twice the response as was seen in patients who were never smokers. And I would say that other data sets are even stronger at showing a greater benefit amongst patients who have been smokers. And of note, of course, patients who smoke have a repetitive injury to their airways, and traditionally has been associated with a greater mutational burden. In fact, the lower mutation burden that you see in some patients in the TCGA data or other data sets tends to be among patients with driver mutations, the same patients who have a lower prevalence of smoking. And we were very excited to be able to participate in this effort. First author is Naya Rizvi in Tim Chan's group. It was at Memorial Sloan Kettering at the time. And what they did is that they looked at the PFS association along with the mutational burden, and showed that amongst patients who had a higher mutational burden, they were more likely to have a benefit with respect to progression-free survival with, in this case, pembrolizumab. There's subsequently been a great deal of data that has been largely confirmatory with other PD-1 and PD-L1 inhibitors, although I will say that the data to date has been stronger for an association with progression-free survival than it has been with overall survival. So there is less, but still interesting data looking at antigen presentation and the TCR recognition, as I say, more with respect to antigen presentation. This is a study, and there's just one figure I show from, again, Tim Chan's group at Memorial Sloan Kettering at the time. This is Chowell is the first author, and this study really looked at whether or not it was beneficial to have a more diverse HLA repertoire. And this study really indicated that in general, if you had a more diverse HLA repertoire, more ways of presenting these mutant peptides to the immune system, it functions similarly to having more mutations. This has been an interest in my group as well. We have a forthcoming manuscript. Amy Cummings is the lead author here, showing that in patients who have particularly good affinity with non-small cell lung cancer, particularly good affinity between their neoantigens and their respective HLA or MHC molecules, that group of patients did particularly well. I think in lung cancer, there is more data on overcoming immune checkpoints. And this is really, I would say, where lung cancer has been the sort of example in many respects. So, and I think that one study that does illustrate this nicely is a study I was very involved with, the Keynote-001 study. This was on the initial report of 495 patients, although eventually there were 550 patients. And as part of this study, it was a complicated study design in terms of different groupings, but the study itself was pretty simple. Everybody got a PD-1 inhibitor, and then we looked to see what happened, but also looked to evaluate whether or not PD-L1 could serve as a biomarker for identifying patients who would have a long-term benefit. And the answer is that it did. So there was a training set of 182 patients, at which point we sort of selected expression of PD-L1 in at least half of the tumor cells as the grouping to look at. And then there's an independent validation set that we looked at to see whether our testing would be informative. As you can see, there are multiple different cut points that could be assessed. But the one we chose, as I mentioned, was what was called at the time PS of 50%, meaning that there was staining for PD-L1 in at least half of the tumor cells. And as you can see, this sort of nicely broke groups down into three groups, which really has been maintained to this day, looking at those who have no PD-L1 expression on the left, those who have lower levels of PD-L1 expression in the middle, and those with high level of PD-L1 expression, PD-L1, of course, in brown here. And you can see that you can generally tell pathologically the difference between these groups. And one thing that is nice as a biomarker is, at least in lung cancer, most people are either negative for PD-L1 or low expressors, or they have a high degree of PD-L1 expression. There aren't a lot of people who are right around that 50% cut point. And as you can see here, the survival in that initial cohort really very much favored the patients who had high PD-L1 expression, and now we have 5-year data as well, which showed that of these patients with high PD-L1 expression, over a quarter of them remained alive 5 years later, whereas it was about half of that in patients who had lower expression for PD-L1, and was really a very small percentage in patients who are negative for PD-L1. And although I think this biomarker is still very much maligned, it is not a perfect biomarker. I do show this waterfall plot that shows how it performs versus what we would consider in general an excellent biomarker or two excellent biomarkers, ALK and ROS1 gene rearrangement for crizotinib. And as you can see, although PD-L1 of greater than 50% in this Keynote-001 dataset performed a little less well than these two genomic abnormalities for crizotinib, it still performed, I would argue, quite well. The data that I've shown is for PD-1 inhibitors. There has been a great deal of similar data for PD-L1 inhibitors, and I'm sure you will hear about some of that over this session. I think the one additional, sort of checkpoint inhibitor issue that has come up a great deal is the one looking at the combination of nivolumab and ipilimumab. This data has been somewhat polarizing, as it is clear that nivolumab plus ipilimumab is better than chemotherapy in this setting. I think it has been hard to isolate exactly what the independent contribution of the ipilimumab is, but what you can see is at least a hint of a better outcome for nivolumab plus ipilimumab versus nivolumab in patients who were positive for PD-L1 in terms of overall survival as well as progression-free survival. And for these patients who have PD-L1 expression of at least 1%, therapy with nivolumab and ipilimumab has now been approved by the US FDA. Although not approved by the US FDA, the data did also look encouraging among patients who had low levels of expression for PD-L1, actually negative expression. And you can see that data shown here. This is now an available option. This can be given as the 2 immune checkpoint inhibitors alone. And now, based on data from the Checkmate 9LA study, it is also a possibility along with 2 cycles of cytotoxic chemotherapy that has been added because there has been some concern about this idea of what people call hyperprogression, where you may actually see stimulation of the cancer early on in patients treated with checkpoint inhibitors alone. And so checkpoint inhibition has obviously become a very established part of the care, and the role of PD-L1, which of course is one of the checkpoints that, or at least part of the checkpoint axis that's being inhibited, has been perhaps more well-defined in lung cancer than any of the other histologies. So in summary, and I know you're going to hear a lot more about specific immunotherapy approaches over the course of this session and the course of this meeting. But to summarize, I would say in a very short period of time, when one looks generally at how developments occur in cancer therapy, non-small cell lung cancer has gone from an immunologically unresponsive tumor to one that's considered a very important immunologically responsive tumor. There is clear data that efficacy has been associated with more and better presentation of mutant peptides. And I would also say it has been the example of a tumor for which PD-L1 can be associated with efficacy. And despite advances in the field, it still does, that PD-L1 expression still does constitute a significant selector for therapies amongst patients. Thank you very much.